Hello everyone, hope you're all doing good. In this video, we are going to discuss about genital tuberculosis. See, the most common organism that is causing genital tuberculosis is going to be again Mycobacterium tuberculosis in 95% of the cases. So, it is Mycobacterium tuberculosis in 95% of the cases, whereas Mycobacterium bovis can also genital tuberculosis in 5% of the cases, right? So, now how does genital tuberculosis occur? Mostly the spread is going to occur from the extragenital sites, okay? So, extragenital sites means the primary site of infection can be lungs, lymph nodes, urinary tract, bones, or even joints. And in the genital tract, fallopian tubes are going to get affected more, followed by the uterus, endometrium of the uterus especially, okay? And then in the fallopian tubes, the most commonly affected site is going to be the ampulla, and the least commonly affected site is going to be the intramural portion. Clear? Right. Now, what is the mode of spread? Okay, it has occurred in extragenital areas. Now, how does it travel to the genital region? Mode of spread of genital tuberculosis is mostly hematogenous route. Remember, this is the most common route of spread in 90% of the cases where the spread can occur from lungs to tubes. Clear? And other routes may include direct spread. For example, when it spreads from the tubes to the endometrium, and then there can also be lymphatic spread. For example, when the infection travels from the infected organ, say uterus, to the peritoneum, or even it can spread to the mesenteric nodes as well. Clear? Last but not the least, there is a risk of ascending infection also when a partner with genital tuberculosis is there. Okay? When the partner is with genital tuberculosis, right? Now, let us discuss the pathology. Already I told you that fallopian tubes are the most common site of genital tuberculosis, and remember, always, most of the times, both the tubes are going to be involved simultaneously, and the initial site of infection in the tubes is going to be the submucosal layer. From that, they can spread medially, can destroy the muscles of the tube, which can be replaced by fibrous tissue then, following which calcification occurs and there is tubal block presentation. Clear? However, abdominal ostium is going to be patent in case of tuberculosis. The elongated tube with this patent abdominal ostium. Okay, so just like this. The tube is going to distend and the ostium is going to open, and this is going to give an appearance of tobacco pouch. Okay, so this appearance is known as tobacco pouch appearance. And following this, there can be collection of pus inside, which is known as pyosalpinx. Okay, so there can be pus collection inside. And after this, there can be dense adhesions that can be formed with the surrounding structures, and that can lead to formation of tubo-ovarian mass as well. Clear? Right. So, the condition called salpingitis isthmica nodosa can also occur in case of fallopian tube tuberculosis. Here, there is proliferation of the epithelium near the uterine cornua. Okay, so this is salpingitis isthmica nodosa. Clear? Right. Now, we'll pass on to the uterus. So, uterine tuberculosis is seen in 60% of the cases, and as we have already seen, it is going to spread mostly by direct spread, followed by lymphatics, cornuvolence are commonly affected. It can lead to adhesions or synechiae formation. So, what do you call this as? When there are adhesions or synechiae in the uterus, it is called as, very good, it is called as Asherman's syndrome as well. And suppose if there is caseation, then it can result in pyometra also. Clear? Now tell me, what is the most common cause of pyometra? Yes, it is senile endometritis, and most commonly it is seen in the post-menopausal women. Okay, however, this can be also seen in genital tuberculosis, right? Okay. Then coming to cervix, again primary infection is going to be by direct spread. The lesions can be ulcerative or nodular, and this bleeds on touch. Okay, so always the differential diagnosis you have to keep is cervical carcinoma. Okay. Then involvement of vulva and vagina in case of genital tuberculosis is very rare. It can be presenting as hypotrophic lesions, if so. Clear? Right. Let's speak about the ovary. Ovary involvement occurs 30% case of tubercular salpingitis. So, there can be surface tubercles, adhesions or thickening of the capsule also. Urinary tract is going to be involved in 10% of the cases. Pelvic peritoneum is going to be involved in 40 to 50% of the cases. You can have two types of tuberculosis in the ovary. Number one is wet variety, where you will be able to see a straw colored fluid. Okay. Another one is dry variety, where you will be able to see only dense adhesions with bowel loops. Okay. So, mostly they will be presenting with mass. Clear? So, when you take a microscopic appearance of these lesions, you will be able to see granulomas that is infiltrated with multinucleated giant cells. So, what are the giant cells, multinucleated giant cells that are seen in tuberculosis? Langerhans cells, right? And then there can be chronic inflammatory cells or epithelial cells as well. Clear? Right. And center area of caseation necrosis can also be seen in case of tuberculosis. Clear? So, these are the microscopic appearances. Once again, I will tell you, microscopic appearances consist of granulomas and caseation necrosis. Granulomas consist of multinucleated giant cells, which is the Langerhans giant cells, and then you can have chronic inflammatory cells or the epithelial cells. Clear? Yes. So, clinical features of genital tuberculosis. Remember, genital tuberculosis is most commonly seen in the women of child-bearing age group, that is between 29 to 40. And most of these women are asymptomatic. They can present with common signs of tuberculosis like weakness, fever, which can be a low grade fever. There can be anorexia or anemia or else weight loss also. Okay? And the common complaint in these women, since they are presenting in the reproductive age group, is going to be infertility. And remember, it definitely not need to be a primary infertility alone. It can be a primary infertility or even a secondary infertility also. And they can even present with abnormal uterine bleeding, there can be amenorrhea or oligomenorrhea, because already we have seen there can be Asherman syndrome, synetia formation. In that, the most common presenting complaint is amenorrhea or hypomenorrhea, right? Then there can be heavy menstrual bleeding as well. Clear? Right. And sometimes when the woman is presenting with tubo-ovarian mass, there can be complaints of pain as well, and even a blood-stained discharge or postcoital bleeding can also be seen in women those who are having cervical or vaginal or vulvar tuberculosis. Clear? Yes. Now, let us see what are the signs in genital tuberculosis. There is evidence of active or healed extragenital tuberculosis seen. Okay? Per abdomen finding can show you an abdomen with doughy feel because there is mated intestines. Okay? Irregular Tender mass that is seen arising from the pelvis can also be felt during abdomen examination. Ascites, which can be diffuse or encysted, can also be seen. Okay? And while you do a pervaginal examination, you will be able to see bilateral pelvic mass of varying sizes. Clear? Okay? Right. We have to perform dilatation and curettage. Dilatation and curettage. And this is mostly performed in the week preceding menstruation. Because the tuberculosis is usually present in the deep layers and comes to the surface only during this period. Materials that is sent to the laboratory is divided into two portions. First portion you have to send it in normal saline for histopathological examination. Second portion has to be taken for culture in the LJ medium. Then you have to take it for NAAT, that is nucleic acid amplification test. Then AFP microscopy using Ziehl-Neelsen-Stein. Or it can be sent to the gene expert as well. Clear? Right. Serum markers like ADA is found to be increased, adenosine deaminase. We can even take biopsy from the lesions, as we have already discussed the microscopic appearance. Blood leukocyte count and ESR is going to be elevated. Interferon gamma, however, is more specific. Tests like Mantoux test is not mostly done because it is less specific. You can even ask for a chest X-ray to rule out pulmonary tuberculosis. Abdominal and pelvic ultrasonogram, IVU, that is intravenous ureterography, CT scan and MRI can also be done if needed. However, one of the previously used investigations for diagnosing genital tuberculosis was hysterosalpingography, but we are not using it anymore because since the abdominal ostium is open, when you give the dye in HSG, it is going to spill out through the ostium, okay, to the other parts. So, we are not doing it anymore, but even then I just want you to show the findings that we can get in HSG if the patient has genital tuberculosis, okay. So, this is a picture which is showing the terminal sacculation. Are you able to see there is terminal sacculation and occlusion is also there. Can you see there is a gap here, right. So, there is terminal sacculation as well as occlusion of the fallopian tubes on both the ends, right. And this picture is showing floral appearance, we can say. You have a hydrosalpinx that is twisted, okay. This is on the left side, okay. If you see, this is on the left side, you are getting this appearance, whereas on the right side, you are not able to see the tube at all. So, it is completely blocked, right. And this is another picture where it is showing bilateral tubal occlusion, mostly at the isthmic portion, okay. However, you have to remember the fact that in hysterosalpingogram, we will be introducing dye through the vagina and cervix and it will be passing through the tubes. So, the most common cause of bilateral tubal block is going to be physiological spasm because of the dye, right. And this is another pic where you are able to see multiple and they are also irregular defects. Are you able to see? Multiple irregular intraluminal defects. Okay. So, that means this patient would have had Asherman syndrome, right? Anyhow, we are not doing HSG anymore, but still you have to know about these investigations. So, how will you manage the patient with genital tuberculosis? Management is usually done with anti-tubercular treatment that is given for 6 months. So, the regimen is this one. So, let's discuss the regimen also. For the first 2 months, you have to give isoniazid at a dose of 15 milligram per kilogram body weight. You can even give rifampicin at a dose of 450 to 600 milligrams, pyrazinamide at a dose of 30 milligram per kilogram body weight, then ethambutol that can be given at a dose of 30 milligram per kilogram body weight. So, this is kilogram body weight. Okay. So, all these drugs should be given 3 times a week. Clear? And following this for the next 6 months, and following this the next 4 months, you have to give isoniazid at a dose of 15 milligram per kilogram body weight and rifampicin at a dose of 450 to 600 milligram, and this should be given 3 times a week. Clear? Sometimes the patient may need even surgery when she has tubo-ovarian abscess, pyometras, chronic pelvic pain, and the ideal surgery you can do is total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay. However, if the woman is young, then at least one ovary should be preserved. Clear? In case of infertility with genital tuberculosis, you have to advise them for IVF. Clear? So, with this we are finishing this topic on genital tuberculosis. I hope this video has helped you. Until we meet in the next video, keep going, happy learning and take care.